Hello, everybody. My name is Kelly Sandacre. I'm the SUDISA administrator, but I also do the SUDISA and Safe Supply work groups as well. And I'll be reading off the disclaimer before we get started. This meeting is being recorded and will be posted to the HCA website on a webpage dedicated to SUDISA work group. Please begin recording. Michelle has already done that. This recording is open to public disclosure. Please do not disclose any private or confidential information. Guidelines for public feedback. This work group is not subject to the Open Public Meetings Act. Members of the public are welcome to attend and observe the SUD Intake Screening and Assessment SUDISA work group meetings. Meeting participation, including use of the chat, will be limited to work group members unless otherwise specified, i.e. if we have a guest participant, panelist, presenter, etc. If you're not a committee member and you would like to provide comment or questions for the work group for consideration, please email HCAESB5476 at hca.wa.gov, and the work group administrator will share your message with the work group. Oh, you know something. I forgot to share the slides, guys, but I'm gonna share them here real quick. I was reading off them and I didn't share them, but I'm just gonna show them to you so you at least can see them like you always get to see them. So that you did see I was reading off of them. But there's that. Next into the agenda items is group announcements. I always like to just go over real quick about the SharePoint page for SUDISA. All of you should have access to this. You click on meeting materials and you can get to different spots of what we're doing inside this work group. You can click on this and it'll show you how come this work group was enacted. The next discussion that we're up for is professional associations. So at the beginning of this work group, it was decided that associations would not be involved in the actual curtailing of the goals or the recommendations or anything, but that we would at a later time have them provide input in different ways. And so at this time, we're going to go ahead and discuss what are some ways in which we can get input from these various associations. And two ideas is that we could hold a special SUDISA meeting where these associations show up and we invite them and we say, here's our recommendations so far. And this is going to be later on, but after we have solidified everything and we would present it to them, or the HCA, like such as myself or Michelle, could go to associations, to their groups, meet them where they're at, and present the evidence that way too, the recommendations and everything that way too. And I'm gonna just leave it open for a second and see if there's any other ideas about how we can get input from associations and such. If you have any ideas, you can put it in the chat, or you can also just raise your hand, and then I'll call on you, and you can go ahead and speak. Okay, I'm gonna take. Oh, go ahead, Michelle.
Oh, I was just gonna ask, does anyone need a bit more explanation or context for what we're talking about here? So I could add on to what Kelly said.
Well, I was going to suggest, are you going to use like sending out a survey monkey to all the different associations and asking what recommendations they would have or any opinions that they want to give relating to this? That would be one idea, and I can't find my hand to raise it.
Yeah, I think gathering recommendations via SurveyMonkey might be tricky, just because like our process to develop recommendations has involved so many different steps, and I don't know if there's if they'd be able to, I don't know, maybe they'd be able to write in, in like a long form response, some ideas or something. But we were thinking it would be more like presenting the recommendations that this work group has and then asking for feedback or concerns or building upon what this work group had already developed, rather than asking for brand new recommendations, but we could do that as well. And I mean, that's probably a good idea too. But then it would be, I don't know how much of like a back and forth we would need to work with those groups to build out those recommendations in the same way that we're doing in this space with all of you. So I guess it's kind of a, do we do one or the other or both?
I would think you could assemble a Survey Monkey that has all of the things we're proposing changing. And are we taking their feedback into consideration on changing it, or just consideration on different ideas they might want to include? And they can just say if they agree with it or not. But that's just one idea.
Yeah, I think that's a great idea. And that's what we want to know from you is how would you like to solicit the feedback from these different associations? What kinds of questions do we want to be asking them? What are we open to in terms of input, also. So I will, let me just start taking some notes in the chat about other options. So I do know that we can't use SurveyMonkey as a state agency, but we do have our own ways to conduct surveys. So we could do functionally, we have something similar we can use.
Great.
Yeah.
I don't know what I was trying to put, but so do we want to? So I think we have like three options then. Should we invite the associations here to SUDISA? HCA could present to each association, or could a survey with our work group recommendations and ask the association for any additional recommendations? Um, is there any thoughts or other ideas in which how we could talk to the associations? Okay. Michelle, you think we should just go ahead and vote on these with like hand raises? Maybe.
We could do that. I wonder if we have capacity on our end with HCA, if we actually just ask the different associations how they would like to engage. So we could offer what you just said, right? Like we can set up a meeting for us to present. We could invite them into a
Okay.
meeting, or we could just send them a link to a survey to provide input. But if we have those three options, we could just offer those options to the different associations to let them choose how they can, how they'd like to provide input.
Yeah, I think that's actually a great idea. And then because one might work better for the other than the other one, so they might like it better to come to the group, and we could just designate two of the SUDISA groups or one of the SUDISA meetings where this is where the associations, hey, we can invite you to this one meeting to present to you, and that's when we can provide all for other associations, or me or you can present to them, or we can present them with the survey. I think you're right. If no one has any issues with that, I just like to present these three options to each of the associations, and then let them choose.
Okay.
All right.
This is Brandy. If I agree with those, whatever works best for them. If they came to this meeting or one of these meetings, what would be our role in that by
As work group
having,
members?
yeah, what would they be presenting, or what would our role be as work group members?
I think the benefit to having them come to a work group meeting rather than just the HCA folks presenting is that all of you would be present to explain your perspectives and provide a bit more context for your own experience that has led to the different recommendations. So they'll get more of the background and context for why we came up with what we did. And some of you are probably going to be able to answer questions that just the HCA folks would not be able to. But otherwise it would be similar to I think the presentation we would give at one of their meetings, where it's like, this is what we've come up with, like now we can have a discussion about it and what you think, but with the support of all of you present also. Which I think is more ideal, but.
Meta?
Yeah, I might have missed this part, and I know that we, at the very beginning of the SUDISA process, we discussed that, the group composition, whether or not it should be representing organizations or associations. But when we say the associations, do we have a specific list of entities that we would be approaching?
I'm sharing it right now.
Yeah, are you able to see the shared screen?
Oh, yeah, I can see it now.
I actually didn't explain that. That is a little bit my fault. So everybody, if you look at your shared screens right now, if you haven't looked at them already, these are the associations we're talking about.
Yeah, so Washington Association of Drug Court Professionals, the Washington State Hospital Association, Association of Alcoholism and Addiction Professionals, Washington State Association for Addiction Professionals, Designated Crisis Responders Association, SUD College Educators, Association of Washington Health Plans, Washington State Office of the Insurance Commissioner, Office of Tribal Affairs, Washington State Medical Association, and Washington Association of Addiction Treatment Professionals. Oh, so also, if we've missed any that you're aware of that who would probably be interested in providing input and interested in the recommendations that we're putting forward, anyone that has a stake in, all of this, happy to add that in. But these are the ones that we've identified so far.
And also too, if I've been to the website for designated crisis responder, and I've already talked to Dominique right before this meeting. If anybody has a email for the Designated Crisis Responders Association, that'd be greatly appreciated. I've emailed their site, their info site, but that was emailed back in October of 2023, and I'm guessing we probably didn't get a response back then. And I've emailed it now on 7/5, so it was just this past Friday I emailed them. They could respond, and I'll have an email then. But if anybody has a direct contact with the Designated Crisis Responder Association, that'd be greatly appreciated. You can put it in the chat, or you can email it to me, whichever one's easiest.
This is Katie. I'm wondering if I've gotten emails from Zephyr Forrest over at the HCA regarding DCR issues. I wonder if they might have a good contact for you.
I'm looking them up right now. Okay. You said Zephyrus?
Zephyr Forrest. I'm putting it in the chat.
Oh, okay, good. Yeah. Okay. I will make contact with Zephyr Forest and see if they might have contact with someone at the DCR Association. Thank you so much for that. Appreciate it. Okay. I have that email set up to go after this meeting. All right. Does anybody else have anything to say on associations at this time? All right, I see no hands. Oh, thank you, Brandy. I don't see any responses. I don't see anything. Okay, Tony, we will add that. All right.
I do notice that we have someone from an association on the call. Would it be all right if I solicit feedback from them now before we move on? Not about recommendations, but about how to, like, thoughts about how to reach out. Yeah. Steve Frang, uh, are you able to unmute and share any feedback if you have, if you don't, then that's fine too, but I just noticed that you're on and curious what you think.
In terms of notification of the association, I would basically email Christina Mason, who's our chair, and she'll make sure that it gets distributed throughout the board and any interested members.
Excellent. Thank you. I appreciate that. Okay. All right, Kelly, back to you.
Yep. Thank you, Michelle. All right, now we are going to get into the nitty gritty of all this stuff. Thank you for the association conversation, folks. Me and Michelle are going to take this back and we're going to work on it, reach out to some folks and start reaching out to associations and getting feedback from them so they can help give suggestions further to our recommendations and such. So this is the document that me and Michelle have been working in from the mural. So all of this information, with the exception of the goal 3s, all of the goal 1 and 2s have been added to this. And basically this is a form. If any of you did the subcommittees at CIRSAC, this form is similar to that. And so we got a form and we kind of moved over the stuff from the mural now over to this Word document so we can start processing it. And I guess our idea is that as we're processing through this document and these recommendations, we would hammer down which ones are realistic. We know we can make changes with it and where we can go further with it. And so we might go through a recommendation, like something we put on the mural, and then we go through it and we're like, well, wait, we don't have like a real way we can actually make this happen at this time. So we're going to have to backburn this one and go to the next one. We know we can make this happen. And so that's just something to think about as we go through this process. Also, too, there might be times when me or Michelle might have to meet with you individually offline and get with you to get the information. And we'll go back to this document. Michelle, is this document in the SUDISA SharePoint?
I don't know that I've uploaded it yet, but I definitely, if it's not, I will after the meeting so that we can start collaborating together on it. Yeah.
Yeah. And so yeah, and I'll periodically probably download this document as well, so it's saved. So if somebody accidentally does something, then it can always be saved. I can get an older version. But yeah, so we separated between goal 1 and 2 in this Word document. And then we put the information in there. We might split up in smaller groups at sometimes with everybody and ask and work on each of them together. I've broken them up between lines so that we know when the page ends. That means that ends that goal, that recommendation is ended with that line. And so I don't have them really numbered right now, but this is what I have so far. And so if we want, we can actually just get right into this. Oh, nope. Brianna?
So I know I had sent this to you to, I was hoping for it to be broken down further, so that each recommendation can have each of these items, regardless if it's goal 1 or goal 2, so that so everyone has an understanding of each one, because what I'm hoping to do is to break it down further, and if legislators want to implement any of these, they're not tied to like one whole thing. They can take it as a whole, or they can piecemeal it as well, just giving them that option when I'm writing the report. So these should be broken down per recommendation made.
They will be.
That goal.
Yeah.
Yeah, they will be. This is the very beginning stages for us. We just put the information on the paper for right now, well, the Word document, and then our goal is to really break it up between members and really start talking about each of these and making it a whole thing. Did you want to say more, Michelle?
Yeah, I was just gonna say, Brianna, I think maybe it's hard to see, but there's like 6 or so sections, right, that you wanted it broken down per recommendation. And those are copy pasted over and over again throughout the document. There's several for goal 1, under goal 1, and several under goal 2. So yeah, so we are breaking them down in those sections per recommendation.
All right. Okay. I didn't see it further down. Okay. Thank you.
No, thank you,
Also, I will
Brandon.
say this is I just want to add real quick that this might be subject to change because it has not gone through leadership approval. So just FYI. Sorry.
No, thank you, Brandon. Thank you for everything you said, because I think you pointed out a good, because I hadn't told everybody, like, yeah, each of the recommendations. So you'll see it, the line, and then you'll see the new recommendation written. So, so everybody can see it. Michelle, were we thinking of breaking up in to smaller groups, or just as a group, just like doing the first one together, or?
We're gonna need to do it all together today.
Okay.
In future meetings, we can break up into small groups if that's helpful.
Okay.
But since you want me to take notes, if you could stop sharing yours and I'll pull it up on mine, and
Yeah.
then people can see how I'm changing it. Yeah. Okay.
Yeah, I think you're right. I think that's gonna work out way better.
Okay. So we're gonna need to draw on the memory of folks who put forth these recommendations to begin with, and just try to build on them and make them a bit more coherent. We're trying to find like specific actions that we're asking the state to take to improve the systems or change policies or processes around this. So what's highlighted is what we basically what was translated from the mural. And so it's shorthand, right? So we need to make sure that we build each of these out. So yeah, I guess Kelly, if you wouldn't mind just leading the discussion, I'm happy to help as well, but I'll focus on notes.
Yes, for sure. So okay, so and oh, go ahead, Susan. You found your hand.
Yeah, this was my suggestion. And so I thought if I could clarify what I meant, or did you
Yeah, go ahead.
did you want to talk about it? Well, I've learned a little bit since then. And I believe that the answer to the question for the THC or the syntax is that is being applied to preventative measures, but even the budget person for the Department of Health didn't know for sure. So maybe it would just be identify where the funding is coming from, or, you know what I'm saying? Where are those proceeds going? It just seems like we have such a shortage of funding that it would be worth looking into.
Mm-hmm.
So is the recommendation to use tax from like cannabis products, THC?
Yeah.
Toward...
I had thought that there was money that was going to be applied to that, but apparently it may not be. But it seems like, we have smoking, tobacco, soda pop, all these extra taxes that go to people. They label them the sin tax, all the things that aren't healthy that they've put additional taxes on, and the THC industry is paying a fortune, I'm sure, in taxes. And is any of this going to substance use disorder treatment, since it's all kind of related? I mean,
Yeah, actually, Susan, good point, because when I was at the AAP conference, they did a special thing on the cannabis tax, and they were talking about how you only have to have when the initiative went up, it said, hey, all this money is going to go to to like certain things, prevention, adolescence, all this stuff. And then I guess after a certain amount of time after the initiative, you only have to provide money towards that. And so now I believe, and I could be wrong on this, so if there's anybody on the call that can correct me on this, but what they said in the AAP is that right now the cannabis tax is going to general funds.
Yeah, and so because our
I like to come back to us.
reimbursement, yeah, our reimbursement rates are so low. How can you pay staff a livable wage if you can't get reimbursement that is sufficient to do that? And so if the legislature can, or whoever can look at where these proceeds are going and how they could benefit people that need it.
Mm-hmm. Do you want the recommendation to be that reimburse, like, is the primary recommendation that reimbursement rates and wages for substance use treatment providers increases? Like, is it
Correct.
how important?
Yes.
Yeah, and that one way to do that could be through tax from this other
absolutely
source, right?
Okay. That's what I mean. Thank you.
Okay. Yeah.
I knew you'd figure it out.
Michelle is a great decoder.
Is it correct to say substance use treatment providers, or is that too narrow in any way? I just want to make sure the language is precise for what we mean here.
I think it's just for substance use disorder treatment, because it's
okay.
Insurances are not paying enough either, and state.
Oops. Okay.
Hey, Michelle, I do have a hand up from Steve. We've already heard from him once, and I'm cool with it going forward. Does anybody have any issues with a non-member going in and sharing at this time?
I just have a quick
comment. All right, go ahead, Steve.
The rule is for any initiative that passes in the state, regardless of what the revenue and spending menus are in the original language, after 2 years, all bets are off. And the legislature can essentially do whatever they want with those funds. And you're correct in saying that all of those funds are now going into the general fund. None of it is going to any of the specified programs or expenditures that were originally in I-502. Just so you know.
Thank you, Steve. Yeah, no, I appreciate the backup on that. Thank you so much.
Thank you.
Okay.
Hey, Sean, I see your chat message. I'm gonna look into that, and I'll get back to you. I'm pretty sure that it doesn't, but I'm gonna look more into that and see.
I can't see the chat. What was said in the chat?
Sean is saying the dedicated cannabis account does have some stationarily, I don't know if I'm saying that word right. Hey, Sean, what's that word? Stipulated expenditures, right?
Yeah, statutorily stipulated expenditures.
There we
go. I think that the dedicated cannabis account is still a thing, and it's RCW 69.50.540.
I'm reading it right now.
There are some expenditures that are still active there, but yeah, you'll have to double check me, but it does look like that there's still some stuff that you have to spend in the behavioral health space, cannabis appropriations on.
I'm going to look in to see how much
tax receipts.
I'm going to look further into that and look and see how much it is and such. And yeah, Susan?
Well, and to include, I mean, more specific, I mean, alcohol is being overly taxed compared to buying tomatoes. So where is that extra going to? I mean, it's not just cannabis. There's a lot of
Mhm.
taxes for cigarettes and other substances that are addictive that we'd have no idea where they're going.
Mhm. Agreed. Thank you, Susan.
Quick question. Has anyone given thought to how much of an increase or any specific numbers that we might be able to include in this recommendation to say that this kind of this wage or this reimbursement rate would be ideal or sufficient in order to encourage more people to stay in the workforce? Because that is the ultimate kind of impact that we're trying to have, right? To keep people in the field and even broaden it to improve access to services and availability of services, correct?
Teresa?
I would just remind folks that in the Medicaid space, over the last couple years, there was a pretty large project with Milliman, our actuary. And Milliman worked with the, for the behavioral health agencies. They worked with providers, the AAP Council, the Washington Behavioral Health Council, and put forth, I think, 2 different reports on what is called the comparison rate study. And that is a study that is basically putting forth data and recommendations on what rates, like what would rates look like for both for rural, urban, different regions, and what would be sustainable in the various realms for services, so both mental health and SUD. We are in the 3rd phase of that work per the legislator, and I just want to, one of the recommendations, one way to phrase recommendations would be, to fully maximize that work and to encourage the legislator to do targeted increases in accordance to that data. So anyway, that it's for the Medicaid space. It's particularly around managed care, but one of the things that could come out of that work is what is called a minimum fee schedule. And the minimum fee schedule would be set for both fee for service and the managed care side of the house. Again, this is for licensed behavioral health agencies. It's not for those of you that work on the physical health side of the house. But for licensed BHAs, it could set basically a floor that would be higher than what is today.
Thank you, Teresa. That's really helpful. And also great to hear that that work's already underway, and so 3rd phase, is that 3rd out of 3?
Yeah.
Okay, great.
All right. Thank you, Teresa. Yeah, I'm chatting with you right now to get the specifics for later. Hey, Michelle, I'm chatting with Teresa to get the specifics on that so I can add it to our work group stuff later. So lack of services being provided, lack of staffing, ability to bill insurance. So I guess that's all the stuff we just talked about.
Yeah, and that's great because it provides a bit of background for this recommendation
Mhm.
as well. We can talk about, if we want to move on to the next part, the need, like what need this would help address.
Susan, you got something real quick?
Yeah, I just looked up the median income for Washington State is $77,000 a year, which would break down to $34 an hour. That whatever proceeds would give that amount, or even a little less, but at least in the medium income for people that are SUDPs.
Thank you, Susan. Appreciate that.
Yeah. All right. Let's see. So if we want to talk about the need, or the barriers that are overcome by this recommendation, the need, you know, we might need to assign someone or ask for a volunteer to look up some information, some data, some research around it. I think it's clear to the legislature that there is a need. I mean, broaden the workforce was one of the primary goals that they set for us. So in a way, it's already, we probably don't need to argue the need all that much, but just in terms of strengthening the recommendation, and especially if we want to get into a bit more detail about the need in certain areas of the state to broaden the workforce and the level of reimbursement and wage increase that would be needed in those areas, I think that would be really helpful. But it's going to require a bit of research and information digging. So is anyone willing to work on that, and maybe or we can, you know, we can try on HCA's side and use some of our state level data for that as well. No volunteers to do research? Okay.
It might be worth talking to somebody.
Oh, we got somebody. We got somebody. We got 2 people now volunteering.
Oh, okay. Who is that? I can't see the screen except for what I'm
Yeah, I
sharing
know.
right
It doesn't
now.
feel. I know. Whenever I'm sharing it, yeah. Alicia and Charnay. Am I saying your name correctly?
Yes, you are.
Okay. Yeah. So Alicia and Charnay have both said that they'd like to go ahead and look into this more and further. You guys can choose whether or not you want to collaborate together at some point and talk to each other. If you need each other's emails, let me know. You shouldn't, because if you go to the calendar invite, you should see each other's emails, I think. But if you need anything, just let me know, and I can make it happen. If for some reason you two want someone from the HCA involved, you can email me, and all 3 of us can meet together to talk about this as well.
Okay. That sounds good to me. What about you, Miss Alicia?
That sounds good to me as well.
Awesome. I'm right in the middle of research stuff because I'm going into the 2nd year of my master's. So I'm like, hey, give me some more opportunity to research.
At the end of this meeting, I'll send you guys an email saying, you know, like, hey, this is what it is. I'll send you guys all this just so you guys have it. But it's also going to be in the SUDISA SharePoint page as well, and just kind of serve as a reminder. So I know, looking at this right now, you say yes, and then you're like, man, what did we talk about again? Also, too, we'll have a recording of this video, so if you want to go back and watch it, you'll be able to have that availability as well.
Awesome. Thank you.
Yep.
Maida, you were starting to say something also. Did you want to finish that, or?
Oh, I'm sorry.
Yeah, I was just going to suggest that maybe somebody could reach out to. I know we got some really good feedback from. I think it was someone in budget around FTE amounts for peers, and I wonder if they also have some sort of ballpark, like when you're doing a grant from HCA to fund certain kinds of positions, there might be an expected range there, which might provide some guidance.
And building off of that, like, not only SUDP wages, but do we want to look into what average like peer wages are also? Because we know we need to get that reimbursement increased. I mean, that's my opinion also. So maybe we could also include some of that information, because they're kind of, come together.
I'll go ahead and thank you for that, Meta, Shanae. I'm going to go ahead and take a look into that on the HCA side, and then I'll let you 2 guys know after I do my research and talk to budget what they have for me, and if they have some good stuff, I'm going to send you guys an email with that information.
All right, that's great. I think that's a really good start for the needs portion of the recommendation. The next subsection here is the anticipated impact of implementation of the recommendation. So, and this kind of goes both, positive and also potentially, for lack of a better word, negative. But sometimes a recommendation is not perfect in its impacts, right? But hopefully the good outweighs the bad. So anyway, that's what we're trying to consider here. So the desired impact that we expect, and also considering any reasons, any downsides to consider around it.
For instance, we have one that says, if we don't have enough people working in the field, and this is already happening, we have facilities closing because people just don't have the support, or not support, I'd say the employees being kept, and so that's one of the implications of anticipated impacts when we don't have a broad enough workforce.
Yeah, and that would actually probably fit into the need then, because that's a justification to do it, right? So this next part would be more once, if it was implemented, if they did follow our recommendation, what do we expect to happen? And again, it's mostly going to be good stuff, right? That's why we're recommending it, but we also want to acknowledge if there's going to be any kind of downside that should also be considered. So we can talk about, either of those, like the anticipated benefit and then any potential side effect. I'll just say, because it seems obvious, is just broadening the workforce of professionals able to conduct SUD assessments and provide other types of substance use treatment, thus increasing accessibility and availability of treatment options throughout the state.
I can't think of anybody that would oppose it. Of course, any kind of tax. I think some people don't like taxes, of course. But other than that, I can't think of anybody in the human service field, at least, that would oppose an increase in wages.
I
think a lot
of it.
Go ahead, Meta.
Sustainable.
Go ahead, Teresa.
Yeah, a lot of it's sustainability, right? So, like when you're working with Medicaid, when we set rates or raise rates, they have to be what is called actuarially sound. And when we increase services, add providers, or increase rates, there's a financial load onto the state because there's a match, right? When we use Medicaid, it's not all Medicaid dollars. We also have to put in general fund state dollars as a match. And so anytime you increase, right, rates, services, add providers, expand, you're also putting the financial load onto the general fund state fund, if you will. So it's just something to think about, and that's why we have to have like legislative authority to increase rates, right? Now, over the last couple of years, the legislator has increased rates, I think, by like 22% over the last several years. So, they're doing that, and it takes that budget authority, because it's not just federal dollars, it's also the general fund state dollars that have to go in. So just food for thought, and it has, at some point, I think overall, right, we're worried that our our healthcare has just gotten so expensive, right? Like we just, you know, at some point it's like, how do we sustain this over time?
Mm.
And I think the BHAs, and I speak from that perspective, the behavioral health agencies are particularly challenged because they tend to rely a lot on Medicaid, right? And then a little bit on general fund state dollars, a little bit on block grant dollars. But I just think it's really hard to make that, you know, all of that to come together in a sustainable manner, to fund everything, all the operational costs.
Yeah, thank you,
Thanks, Teresa.
Teresa. Mm-hmm.
Any other input from any other member about anticipated impact? You can just raise your hand. You just want to move on proposed recommendations, Michelle?
Yeah. So this is basically just a restatement of the recommendation above. The summary will have a little bit more once we build out the rest of it, because it's just a short version of everything else in here. So I'm just going to copy paste and then we can move on. Although I am noticing, did we address this part about the encouragement of communities putting forward certificates of need? Was this related to like the rural versus urban need? Or is this something additional?
It was one of the
And
it was one of the pink stickies for it.
but we haven't talked about it as a group yet, right?
Yeah.
Today. Okay. So if anyone has more to add around this piece, what we need to kind of clarify what this is. Encouragement of communities putting forward certificates of need to help identify needed services and work with Department of Commerce during award process if available.
It's possible the person who wrote that is not in attendance today.
Okay, but that sounds, I mean, I could be wrong, but that sounds like a slightly separate recommendation.
It does to me. If anybody else wants to speak on this, maybe.
I think that, I mean, Commerce puts out capital grants, right, for facilities to stand up. And there's been, you know, kind of a concern the way that that's done, where providers, you know, bid for the RFI or RFP, and they need to get letters of support, but they don't necessarily have to have like a formal, the region doesn't necessarily have to have a formal assessment that shows the need for that facility or service. There's no formal certificate of need. That's a term that's often used for like hospitals, when hospitals get stood up, a certificate of need, if you will. And I think, I believe DOH has a formal process for that, but not for our facilities, right? And so I think in general, what's happening is, so back in the day, the RSNs and the BHOs, you know, had more of a regional lens and really, you know, had that regional lens, would kind of assess what was needed for the region and really like shepherd that process. And then with the current state, you have 5 MCOs and an ASO and accountable community of health that's not really like on the hook to shepherd building new capacity, right? So what I'm seeing in that statement is just like almost a recommendation to dial it in.
Mhm.
You know, but I'm just reading between the lines.
Teresa, I'm just quick question, maybe, and I don't know if anybody else would have this question. How many people you think are aware of like that there is a such thing as putting forth certificate of needs? Best guess, ballpark. I'm like, do you think most of the people know about it, like in the field, or most like CEO people, or most nonprofit people?
Well, I mean, what I was saying is that term, there's a formal process for like, I think for hospital, I've heard it used over at DOH for like hospitals. I don't think that what I'm getting at is for the behavioral health space, right? There is no formal
Okay,
certificate of need
gotcha.
process. It's
Okay.
lacking. It doesn't exist.
Okay.
Okay.
And so then becomes this kind of squishy process, right? Commerce puts out a capital grant, people, you know, apply for it if they're interested. You know, they have to show letters of support, but does that region really need that facility, right? Is there any formal process that's actually demonstrating that or supporting that, I think is a concern.
No, thank you, Teresa. You definitely answered my question for that, and so that's very interesting. Certificate of need.
Yeah, and I just made a note that we need to build, you know, kind of note that as a separate recommendation, because that's yeah, just different than the recommendation to increase reimbursement and wages. But it's still you know, supportive of goal 1, I think. Maybe goal 2 a little bit too. All right, so moving on to the next subsection for this one, and we're still in the recommendation of increasing reimbursement and wages for substance use treatment, collaboration and existing programs. This is where we just want to think about whether there's any partnership opportunity, collaboration opportunity, overlap with existing work happening here. So for example, that the studies that Teresa mentioned would probably fit in here as well, since that work overlaps and will help to inform what happens with this recommendation. So I'll just make a note of that in just a second. But does anyone else have any thoughts about overlapping work streams around this or other collaboration opportunities?
I wonder if the union program would have anything to say about this recommendation as far as wages goes. The new apprenticeship program for SUDP's behavioral health. Susan?
They probably would. I spoke to them a while back, and their starting wage for an SUDPT in the apprenticeship program is like $18.50 an hour. But it's funded or was sponsored by a lot of big players.
And they have a lot of research in this realm too. They got I believe they got money from the HCA or DOH or something from the state, I think. And they did a lot of research before doing the apprenticeship program. So I'd be curious about what they have to say as far as money goes. If they have any research they've done in this.
Sorry, I didn't follow that enough to know what to write here for the note.
Maybe I could reach out to the apprenticeship program and ask them if they have any like formal research and wages, or if they took in anything like from their respondents, you know, SBTs, like on what they think pay should be, or if they have anything like that. And so I'd be curious on what they have to say.
Yeah.
I think it's like 1099 Northwest Union or something like that.
Okay.
1199.
Okay. Great. And then the next piece is the financial impact. So we talked a bit about the funding that would be needed to make it sustainable, and also reaching out to budget and getting input from those folks. So I think that will cover a bit of the financial impact, but if there's any other thoughts about the funding for it or how much it's going to cost or other kind of side financial impacts. The prompts here say, does this recommendation pose any potential financial impacts to programs, grants, or state budgets? What are the recommendations to address in monetary adjustments to the system, policy, and procedures? So it seems like we have already touched on a lot of that, but just want to open it up again in case there's more thoughts.
Would you be so kind as just move back up and just show the recommendation again? Sorry,
Yeah.
I'm losing the
No worries.
thread.
Yeah, for sure, for sure.
I'm like, what are we talking about?
And
sorry, I need to go
this
right back
part,
up.
yeah, it's this highlighted piece here.
Oh, okay. This is still on the rates, reimbursement of rates.
Yes. All right, and we can always come back, to each of these as we work on the document together on SharePoint. So, and then the final piece that we cannot address together right now is the SURSAC feedback. So, at some point we'll share the recommendations with the Substance Use Recovery Services Advisory Committee, which was the entity that originally recommended that this work group be put together. So we'll want to solicit some of their input and consider that as well as we're finalizing recommendations. So we'll put a pin in that for the time being. But basically that's how we want to go through each of these recommendations. Just make it very clear what action we are recommending for the state to take. Consider, be providing any kind of background, demonstrating the need for it, any kind of anticipated impact that we anticipate, the impact that we anticipate around it, etc. So that's the process that we'll need to be moving through together for each of the recommendations. And a lot of that work can happen outside of the meetings. So I'll upload this document to the SharePoint site and make sure everyone gets that link. And so if there are recommendations that you feel you understand very well and you can fill in a lot of this information or at least contribute pieces to it, we'll definitely need folks to be working on this in between the meetings to make sure it gets done. And then we can work through as a group and potentially break out into small groups at future meetings to dive deeper into the work. So in the document as well would be a great place to put any kind of follow-up questions that you might have, like before you know about the need, for example, maybe there's a data question or research question that you have, and then we can do our best to get that information and answer that to help you do what you can for this, for writing out the recommendations. Hope that makes sense. Let's see. So we've got half an hour left, right, Kelly?
Yeah, that's correct.
Okay. Do you want to just do that same process then for the next one?
I think so. I think that the first one we did pretty well. I think in the second one, I think once everybody sees we're doing it for a second time, I think they're going to be like, okay, I could take one of these on and do something. Also, it's important to note, if you see a recommendation, if you think, hey, I want to research this and look into it, but you're like at the end of it, you've looked into it and you're like, wait, no, this isn't this is probably not going to be a thing, then you should probably take that recommendation, email it to me, or just email me a recommendation, and then I'll review it some more, and then I can add it to the agenda for that next SUDISA meeting, and we can bump it up to the top and say, hey guys, so it's been noticed that this one we don't think is going to be able to be really a thing at all. So is there anything anybody here can say that would make this more solidified right now? And then we'd bring it to the group and let the group know. Don't delete nothing. All right, go ahead and move on to the second one. Does anybody have any questions so far? Okay, moving on to the second one, summary. Oh, go ahead, Michelle.
Oh, I didn't have anything. I think I just made a noise. Yeah.
Summary, explain the system, policy, or process change proposed. Better reimbursement rate, higher pay rate for acute detox setting. Review room and board reimbursement rates currently $14.20 per day.
These seem like specific recommendations that kind of fall under that first one we were just talking about.
I know. And this, all folks, just so you know, some of the things I was looking at in our recommendations, they do kind of match up with another thing. Like, oh, this one is kind of like goes along with this one. So, 1 second. Okay. So this one is dealing when individuals require inpatient medical care. Um, hmm. I don't know if you want to read more through this, we can read more through this, and then we can say if this recommendation needs to be with the first one, we can do that at the end of once when we go through it a little bit more, I guess. Scroll down just a little bit, Michelle.
Mm-hmm.
Yeah, this one's for when individuals require inpatient medical care. And so, I mean, this is talking about, this was put on the yellow sticky. I'm pretty sure if anybody else wants to speak on it, they can. But I'm pretty sure this one's been added because when people are inpatient in a hospital, in a medical care setting, and they need to go to, let's say, residential treatment, that's like, it says SUD assessment time restraints because, a SUD assessment can take an hour or two and you're in a hospital, and though the person might be there, the staff might not have that much time to do an assessment and send it off to a residential treatment facility. This could be answered by ASAM, the new addition. So I do feel like, in my opinion, as an SUDP, that this would fall more under the first recommendation with together. I think that they would go together well. But if someone else disagrees, don't be afraid to disagree. It's totally okay. You can say, no, Kelly, I think this is a different recommendation, and then we can move forward on that. I'd just like to hear from anybody that'd like to speak on it. Do we want to try moving to the next one, Michelle?
I think so.
Okay.
So the next recommendation or just the next
Yeah.
piece of this
I was
one?
thinking
Next
that-
recommendation?
Yeah.
Okay. Oh, Elizabeth, yeah, go ahead. Or Beth, right?
Yeah, Beth is fine. So, the previous one, sorry, I know I see you scrolled. I was thinking about it and explain, well, never mind. Assessment time restraints. I mean, these need to be teased out, and that's what we're going to be doing, right? There's more details, for each bullet point.
Right.
Okay. I know you've probably already said that. Thank you.
No, I haven't. I mean, we're teasing it out together if we can in this moment, but we also acknowledge that some of this takes, you got to sit with it and think about it, and it might be easier to take a look outside of the meeting, right? So, yeah.
Okay, thanks.
Yeah. So this next one, for the summary, the recommendation says peer case management / follow-up. So it's not super clear to me what the recommendation is with that, but I'm hoping that rings the bell for someone and we can elaborate on this.
Go down just a little bit, Michelle.
Oh, sure.
Yeah.
So this is the recommendation.
Yeah, go ahead and sorry about that.
That's all right.
I had a feeling, I was like, I don't think that was what I was trying to say.
Does
Elizabeth,
peer
your hand.
case management follow-up belong somewhere else? I mean,
I think that it's a part of the recommendation, like one of them.
This is Brandy. I know there was a couple of people on this meeting that recommended this, and I was one of them that supported this, or part of this recommendation as well, as that. And I know that it's been expanded, I believe, that peer support services and there's crisis settings in which they can be utilized or, billed for prior to the assessment, but most, it's still not possible for outpatient services or, so peers have an amazing skill set in engaging individuals coming into services. And, the fact that peers technically and most behavioral health agencies can't provide services until after the assessment and the treatment plan has been set up, approved by an MHP or an SUDP. So I just think engagement ways, and I'm sure there is some sort of outreach code, but it doesn't mean that it's accepted by all MCOs or is even technically outreach isn't a Medicaid funded service. So it would be nice that peers could do more engagement and getting people in. I don't recommend that peers do the assessments. That was part of some people's recommendations or my interpretation of the recommendations on this call, because I don't see that needing to be their role, but I do believe that engaging individuals until they can get into a services or an assessment when there is that type of wait time, to get in, help them with resources or keep them engaged until assessments can be done. That would be an added bonus. So they're technically getting at least some services until they can have the evaluation and treatment plan. But I would also allow the peer critical feedback in regards to the development of the plan for the patient when they've had peer contact before the assessment.
Brandy, will you let me know? That was Brandy speaking, right? I saw.
Correct.
Okay. Will you let me know if what I've written is an accurate reflection of what you just said? So peers are often limited to engage. Okay, great. Thank you.
Thank you.
I think that's good.
Is it fair to say, Brandy, is it fair to say that because case management just, has a certain definition and connotation, especially when you're dealing with a Medicaid benefit. But you're mentioning the word engagement a lot. So you're really talking about peer engagement in the context of the peer role prior to an assessment, but you're also using the term case management. So I just want to make sure we're fleshing out what's the scope and role of what you're talking about.
I don't recommend the word case management be placed in there. If I use that, then I apologize. That isn't, I mean, it is different. Not that peers can't provide case management service, but that isn't their primary role. So I do think engagement and providing support services and getting them engaged, not only with behavioral health services, but other services that could benefit the individual until they are able to access. So I don't know. There's a fine line between peer and case management, who's providing the service and the type of service that they're providing. But I do think I wouldn't use, I wouldn't use the term case management because that can be more confusing. You're correct. Peer support, engagement services prior to the assessment.
And I'm pushing on it because I think actually by veering away from the term case management or even care coordination, it actually might be something that we can get approved with CMS and leverage. So I'm being strategic.
I appreciate that. Yes, thank you.
So just to be clear, the recommendation is not to ask for peer case management to take place prior to intake and assessment and treatment, but rather to allow other forms of engagement, such as like referring someone to like say like a peer group or housing resources or something like that prior to treatment and the intake and assessment process. Like if it's not immediately available, right? To have some way of engaging with a peer to stay motivated and ready for the assessment when it comes. Is that right? Is that what we're talking about?
Yeah, I wouldn't include case management at all.
Yeah. Okay.
And then it says in the chat, transportation is a big one we see a need for to get them set up with paratransit outreach, and then Meta says outreach and engagement. Oh, then she put a question mark.
Yeah, outreach and engagement is a service that technically they can do, but it's not, my understanding, it's not a Medicaid billable service. So it's just whether there's state funding that's allowable to provide some of those. And what your maximum contract is to have those. So if peer services could be provided, even Medicaid reimbursed peer services could be provided prior to the assessment and intake.
I mean, that also helps to encourage them to continue returning if we're able to make that connection, because they're like, oh, hey, someone understands. You guys know how it goes. So I'm just adding that in there.
And Teresa, what was it that you said that you were trying to be strategic about something in this?
Yeah, well, just the term case management, when we look at that in terms of a Medicaid benefit at least, there are certain rules around how we craft that. We actually have case management in our state plan. Only at this point, only SUDPs, SUDPTs can do Medicaid case management. And there's just some wonkiness with CMS around like how they view case management. So what I was hearing was more, peer engagement, peer outreach, peer support prior to the person, and kind of fitting that more into the peer role and peer modality. And it is something we might be able to do in the Medicaid space. We do have a modality currently that peers can do that for either mental health or SUD, and that is new as of January of 2024. And I just put it in the chat, the name of it. So that is something we do, and it is prior to the intake, and it is something peers can do. And I think it's part of it is trying to, do we, how is that modality written? Does it need to be tweaked or expanded? You know, is it fitting the need, that sort of thing? Or do we need to look at editing, tweaking the peer services modality in a way that, you know, we did that for January 2024 to allow for crisis work for peers to be able to, you know, engage on a crisis team. So there's things we can do in the Medicaid space. You know, this is where we need to, like, you know, look at what is it that is recommended and how is our state plan not serving us today? How can we tweak it? And then, you know, there is outreach and engagement, but that is that's a either state fund or block grant funded kind of endeavor. But it would be cool if we could actually figure out how to make this work in Medicaid.
Okay. Great. I'm just gonna add that to. Oh, we already did background. Okay, good. All right. And then the next piece is the need. So let's see. Yeah, so any evidence, data, research we can point to there that demonstrates improved engagement and maybe, you know, more completion of intake and assessment, anything like that. If peer engagement is available, or just reason to believe that that would be the case, right? Like, we can't, if it hasn't been available, we probably can't prove that it works. Haven't been given the chance to demonstrate that, but any other kind of research that would suggest that it would, and why we believe that this is going to have a positive impact, would be excellent under this need area here.
Yeah, I'm just thinking, Michelle, and this might spark some ideas for some people, is like, you know, you think about the assessment no-call, no-show rate for SUD services right now. And a lot of people switch to doing open access, which is where you can just walk in and get an SUD assessment done, because the no-show rate, this is nationally, most of the time the number is pretty much close to there. It can be a little bit over, a little bit less, and each of your agencies have something a little different. But most of the time it's a 50% no-call, no-show rate in the SUD field for assessments. I would be curious if there's any other states right now that are utilizing peers in such a way that they start the engagement in a peer way that almost guarantees the person there for the assessment, because of like that level of engagement from the beginning and careness. You know, the person just feels cared for from that. I might research actually a little bit of that. I'm really curious if any other states are doing that. Agencies, if any other agencies are doing that.
This is Brandy. I mean, obviously we're not doing that here. Not that we don't have peers that don't do, well, we have different teams that do some outreach for sure, but I do think I don't know what the research is, and I'd be interested in looking into it a little bit as well to see if we can find something out there. But we work locally with some peer-run organizations that help people get assessments and get into services, and we like go to their facility and do assessments and do things to make it more convenient, because people that are in active use, you know, setting a schedule and following through with it, it's not about anyway, it's difficult to maintain that and to access services while you're actively intoxicated. So I'd be willing to look into it with you or separate and send you some information to see if we can find other research to support this. We use a current organization locally to assist us, and they're more successful because they provide the transportation, and it's not a Medicaid service, but they really, I know, help people coordinate with us and stay in contact with them. And so through the Recovery Cafe that's local here. So we collaborate with that, but if providers could also do it, that would be awesome.
Yeah,
Hey,
thank
so
you,
Brandy,
Brandon.
oh, sorry,
Go
Michelle. Hey,
ahead.
Brandy, so real quick, are you saying that the people that you've seen, that the organization you work with, do you feel, just like, I know you probably don't have hardcore numbers or nothing like that, but do you feel that what you've seen in the field is that when they come from that organization or that peer organization is the one to start the care and then they go to you guys, or you go to them, you feel like there's a higher success of at least attending the assessment or getting work done?
I think for the the individuals with the highest needs or the greatest barriers,
Yeah.
yes.
Okay.
For people who have family members or that will advocate for them and do things like that, they, and will bring them to an appointment if they don't have transportation. So, not to say that it wouldn't benefit everybody, but I think that individuals with the highest, like I said, the longest term potential use, longest use histories and largest barriers. Yeah. So yes, in general,
Okay.
but not every person.
Okay. Very cool. Just curious. Thank you so much.
And if you're interested, they call it the Recovery Navigator program here in Clark County that assists with connecting to behavioral health providers. So.
And Michelle, we have about 4 minutes left.
Yeah, I was going to note that as well. So I think we can probably pause on this work here because we want to talk about the next meeting and agenda for that, correct?
Yeah, we can do that.
Okay, and then I'll get this loaded to the SharePoint, so we can continue the work outside of the meeting. Yeah, thank you all so much for your engagement in this process so far. This has been really helpful.
All right, everybody. So, got a couple minutes left. I'm looking at the agenda. For next week, usually we're putting about an hour, and maybe next week we might have a little more time because we won't be discussing opportunities. But other than going over these recommendations, do you guys feel like it'd be better that we do? I'm willing to hear whatever ideas everybody has, but like teams, we better to have breakout rooms and all four of us go into a breakout room and we work on one recommendation, come back together as a group and explain it and ask for bigger ideas. Um, do you want to assign a team and then all that team meets outside of the group and they'll do the research and meet together? I'm willing to hear what people have to have at this time. If we run out of time, then I can discuss it in our next meeting. But
This is Brandy. If the work group time can be utilized effectively by using breakout sessions, I think that would be great, like you said, and then coming back, for example, if we spent an average of 20 minutes on this one topic, we could have 5 breakout rooms doing the very similar, discussions, maybe choosing which breakout rooms that people want to go into, maybe could be kind of an option so that we're getting, or I don't know, somehow choosing the members effectively for the breakout rooms so that either their expertise or their desire or it was their recommendation from the beginning, for example. But I think it would be an effective way of utilizing the work group time and then spending like the last 30 minutes or hour or something explaining what each work group did to get overall feedback would be more effective than just the large group discussion.
I love that idea, Brandy. Is there any? And yes, Angela, I see your chat related to individual experience. I think that I looked at the list of all your guys' stuff and of the committee of the work agreement. I think I can make that match up pretty well. But just so you know, like there might be someone on here that you might be with a thing because that your expertise may be one of the things that match up or something. But I'm gonna try. I can try my best. I think to match up expertise to recommendation because that will make the recommendation go by faster. I feel like, and so yeah, Elizabeth.
Do you think you could, create the groups at the beginning of the session? That way we could be where we want to be, whether it's with our expertise or some other topic that we have a passion for.
Yeah, that's possible, right, Michelle?
Yeah, I think it's easiest that way. We've kind of pre-assigned. Yeah.
Okay. Yeah, we
Mhm.
can do it that way. All right. Well,
Pre-assigned
everybody, we
based
hit.
on where people want to be. Sorry. Yeah, go ahead.
Okay, no, that's good, Michelle. I was just gonna say we hit the 30 minutes to 2:30. So I just want to tell everybody thank you for being here. This is a great work group. I'm glad all of you guys showed up, and I think we're definitely making a difference in people's lives every day as we do here at the Healthcare Authority. And I appreciate each and every one of you. And yeah, thank you so much. Thank you, Michelle, for being today's note taker. Appreciate you very much for doing it. All right.
Thank you.
Thank you.